Hello, everyone. This is a lecture on etiology. And actually, I've taken a rather extensive lecture on etiology and broken it into two, one for one day and one for another day, actually another week. So this is, I think I titled it lecture Etiologies Part 1, something like that. And I will go ahead and share my screen and we will go through some of the etiologies, and then next time we'll go through the rest of them. And let's see, we should be sharing. I'm going to make the screen big. There we go, etiologies of dysphagia. Now, I think I had already mentioned in class that etiologies, understanding the etiologies is extremely important to determining the prognosis for dysphagia and then generating an appropriate treatment plan. And the reason for that is some etiologies get better, some kind of stay the same, and some get worse. And so obviously you need to know that in order to plan appropriately. So we will go through enough about etiology so that hopefully you can interpret the situation with your patient or patients and apply the information that you learn here to determining prognosis. And then once you do that, you can determine an appropriate treatment plan. So here we're going to start out with the major categories of etiology. So I've tried to be all inclusive. I have probably missed something, but I think we've accounted for about 99% with this list here, 99% of what could possibly cause dysphagia. And I start with neurologic disease or injury. Obviously, that's a big one. And depending upon where you work, if you work in a general acute hospital, that would be a community hospital where people go when they get sick. There will be a lot of strokes, and there will be other neurologic etiologies as well. That would be very common. But you may not run into any premature births, which is the next one. That may be limited to specialized hospitals or bigger hospitals, basically. But that would be a second etiology. Prematurity alone, in other words, the infant can be otherwise healthy, and in such a case, probably will be able to swallow, but is too young to do it at that point. Basically, the developing fetus needs to reach a point of about 34 weeks post-gestation in order to, at the time of birth, at that early time, be able to have a functional suck and swallow. Or actually, we're going to call it suckle, and I think you know about that already. Also, developmental differences. An infant could be born at actually full term, but have developmental difficulties that account for the dysphagia. For example, if one were born with cerebral palsy, that could account for a dysphagia. And we will go into some of those later on. Diseases that affect the structure or function of the mouth, the pharynx, the larynx, or esophagus. Now, I'm thinking primarily of tumors and also the treatment for tumors. Sometimes people may be able to swallow with the tumor, but by the time they've had the surgery to remove the tumor and the surrounding tissue, now they have a dysphagia. So that's why I say it could be tumors or the treatment for tumors, and also traumatic injuries. Automobile accidents that involve that region of the body, gunshot wounds, and other things. The fourth one I have listed here is deconditioning. Now, deconditioning mainly means just growing weak from inactivity. Now, who would get deconditioned? Somebody who's very, very sick. Oftentimes they are, for some medical reasons, they basically can't get up and exercise or do anything. They may not even be able to eat because they're just too sick. And over time, their muscles will become so weak that they have difficulty with swallowing. And I think it's especially true of the trunk muscles. Those would be the muscles around the torso, the muscles of the neck. And I found that when, and I don't know about research on this. I think there probably is some, but just from personal experience, when somebody has grown so deconditioned or weak that they are unable to turn themselves over in bed, meaning that their trunk muscles are so weak they can't roll, they generally will have a dysphagia. And from the deconditioning, in other words, they may not have any other etiology such as a stroke or any of the other things that we're listing here, but just simply the deconditioning, which kind of means if you can get them through, as a member of the team, if you can get them through the period of deconditioning, they ought to be able to swallow again. And then finally, respiratory disease or tracheostomy. And this is kind of a new one too, and there is a research literature on this. The most common respiratory disease that accounts for dysphagia is COPD, chronic obstructive pulmonary disease, also called emphysema. And people who get severe emphysema or COPD do typically eventually develop a dysphagia, and it becomes sort of a circular process then at that point, because the aspiration that can come from the dysphagia exacerbates the respiratory problem, and they feed into each other. And we will go into that when we get to the unit on tracheostomy. And also the hole in the neck, the tracheostoma, and the tube that goes through it, the tracheostomy tube, is thought to cause dysphagia. That's a controversial area, and we'll actually go through some of the research literature, but suffice it to say, it does appear that there's some kind of a relationship between the presence of a tracheostomy and the occurrence of swallowing difficulty. All right, now we're going to turn at this point for a while, quite a while actually, to the overview of the categories of neurologic disease and injury. So that was my first bulleted item on the previous slide. Now we're going to break it down a little bit. And these two slides simply list the major categories of a neurologic disease and injury, starting with disturbances of cerebrospinal fluid production, circulation, or uptake, and we'll look in greater detail at that. Intracranial neoplasms, which would be tumors and cancers. We'll look at a little bit of detail at that. Non-viral and viral infections can affect the brain, and certainly these can be etiologies of dysphagia and other problems that SLPs would work with. TIA, which is a transient ischemic attack. We're going to look in a fair amount of detail at that one because it's just so common as an etiology of dysphagia. Also CVA, cerebrovascular accidents, same there. We're going to look at that. Brain trauma, traumatic injury that comes from automobile accidents, gunshot injuries, etc., would be a major etiology. Degenerative diseases such as Alzheimer's disease, demyelinated, I'll try to get that right. Why don't I just say demyelinating diseases, such as most commonly multiple sclerosis. Disorders related to substances, well, I skipped one, sorry. Acquired metabolic diseases, we'll go into a little bit of detail on that because especially if you work at an acute hospital, you will see quite a few people who have that as an etiology. And typically when the imbalance is corrected, if they could swallow before, they'll be able to swallow again, but we want to have some understanding of that category. Then, of course, disorders related to substances, alcohol and drug abuse, etc., and disease related to nutritional deficiency. Now, those last two I'm not going to go into detail on. I'm just simply listing them here as a possible etiology of dysphagia. All right, now let's look in some detail at disturbances of cerebrospinal fluid production, flow, and uptake. Anything that causes an accumulation of fluid within the ventricles or surrounding the brain and the spinal cord is potentially problematic, very strongly potentially problematic. But typically, the reason we're not going to talk about two of them is problems with the production and uptake are really uncommon. Typically what happens that results in a problem is that the flow of the cerebrospinal fluid through the ventricles out into the subarachnoid space becomes blocked at some point. And very, very often it's the drain from the third ventricle into the fourth ventricle, it's about an inch long and it's quite small in its diameter. It goes through the midbrain, and the midbrain is not a very big structure. So just because of its length and the region it's located, it is especially vulnerable to injury. In trauma, could also grow a tumor in that region, and one way or the other, block the drainage of the fluid through the ventricles at that point, which will then result in an accumulation of fluid behind the blockage. That would, the example I just gave, where there's a blockage of the aqueduct of Sylvius in the midbrain, also called the cerebral aqueduct, by the way, results in enlargement of the two lateral ventricles and the third ventricle, and it pressures the brain in all directions. So basically, it causes an accumulation of fluid inside the brain in those ventricles. There are two categories of hydrocephalus. One is called tension hydrocephalus, and the other is normal pressure hydrocephalus. In tension hydrocephalus, there is an elevation of the cerebral spinal fluid pressure. In other words, if they put a little probe into a ventricle, the pressure will be too high. It'll be high. And in fact, they do such a probe. It's called a ventriculostomy. I think I've got it in another slide or two, and so you can see the spelling on that. And if they suspect hydrocephalus, they can look at CT scan, and we'll look at how they do that. But one way or the other, they get to the point where they determine that the cerebral spinal fluid pressure is elevated, and that would be called then tension hydrocephalus. It is an acute problem. It can kill rather quickly, within a day or so. And it causes, because it puts pressure on the brain in all directions, it causes non-localizing signs and symptoms, meaning not something like a right hemiparesis or a left hemiparesis. Those are localizing. They kind of suggest where in the brain the problem is. Something like confusion is the hallmark of a non-localizing neurologic sign and symptom, starting with confusion. That would be the first sign. And it doesn't show the involvement of any particular part of the brain. It shows the involvement of the brain as a whole. Then normal pressure hydrocephalus is hydrocephalus in which there's excessive fluid in the brain, someplace in the cranium, and yet the pressure when they measure it is normal. It's in the normal range. And this can result from shrinkage of the brain due to TBI, traumatic brain injury, a degenerative disease like Alzheimer's disease. In other words, the brain tissue actually shrinks away and becomes smaller. What's it replaced by? Fluid. The ventricles are bigger and the subarachnoid space is bigger. It is chronic, and it is it also causes non-localizing signs and symptoms. All right, there's going to be a little blip, and we'll come back to another slide in just a moment. Okay, there was a little blip there. I went to have lunch, and so I'm coming back to the slide that I left off with. Actually, we did number 5. So you've seen the two kinds of hydrocephalus, tension and normal pressure. And now we're going to look at the diagnosis of hydrocephalus. We could just call it for short hydrocephalus. Diagnosis is always really going to start with a history and a physical. And the physical exam, which would be, you all know what a physical exam is. Number one, it wouldn't reveal any localizing signs or symptoms. So that would be a key finding that could point to many, many things, one of which is hydrocephalus. And but they would discover confusion, or if the hydrocephalus were worse, it could get into problems with consciousness. And literally, if it's really bad, person's unconscious. And then the history is important too. Now that's the story. How did it unfold? And the key part to the history here would be that it's gradual over a few hours or days. Someone is not normal and then they collapse, and that's hydrocephalus. It's not the way it works. So the history would be one of a somewhat gradual onset. One of the tests are going to do, I don't know if it's every time, but very often, if somebody comes into a hospital confused, or if they develop confusion while they're in the hospital, they're going to do a CT scan of the head. And that will reveal the hydrocephalus right away. It will show enlargement of the ventricles behind the blockage. So if the blockage were in a drain from the lateral ventricle, let's say the right lateral ventricle, the CT scan would show an enlarged right ventricle, lateral ventricle. If it's in that aqueduct of Sylvius, which is so very common, it will show an enlargement of the third ventricle in the middle, between the two halves of the thalamus and both lateral ventricles. And then the other thing that it will show is it will show what the radiologists will call effacement of the cortical sulci. In other words, if you look at a CT scan, you can see the sulci, you can see the curve, you know, the gyrations of the gyri and the sulci. But when the brain is being squeezed up against the cranium by the enlarging ventricles and put under pressure, they are not very prominent. So they call it the effacement of the cortical gyri, and also a diminishment of the subarachnoid space. Whereas in a normal brain CT scan, you can see the subarachnoid space. In this case, and it doesn't matter where the blockage is, it's going to squeeze the brain in all directions. And so there will be a diminishment of the subarachnoid space and a effacement of the cortical gyri, and then enlargement of the ventricles, which are behind the block. Then in order to determine if it's a pressure hydrocephalus situation, they will measure the pressure, and they can do that through what's called a ventriculostomy. They have to bore a little hole in the cranium and put a very small catheter down through the brain, hopefully in a silent area that won't produce any neurologic signs or symptoms, into a ventricle that is, they put it into the enlarged ventricle. In other words, if only one of the ventricles was enlarged, they'd make sure to penetrate, and then they can measure the pressure, and they would see that it's elevated if it's a pressure hydrocephalus. They could also measure the pressure down in the lower part of the spinal column beneath where the spinal cord actually ends. And so that would be down around L4 or something like that, with a needle that goes through the skin and into the subarachnoid space that surrounds the whole cord. All right, so I didn't enlarge that. Let me go ahead and enlarge it. So as we move on. I think we finished all of that. There is something called, by the way, a ventriculotomy, which is a heart surgery. So we want to make sure we get that S in there that distinguishes a ventriculostomy that I just described versus a ventriculotomy, which is a heart surgery. So we've got a lumbar puncture and a ventriculostomy as two ways to measure the pressure and make that diagnosis. All right, now the treatment. As far as treatment goes, the brain may swell as a result of head trauma, or actually also certain illnesses, and that the swelling of it can cause one or more of the ventricular drains to close, resulting in pressure hydrocephalus. So this is a real common scenario in traumatic brain injury, is that the brain swells in response to the trauma it's been put to, and it will just start to press everything in every direction. And one thing it does is start to push the brain tissue against the midbrain and close off that aqueduct of Sylvius. So just getting the brain swelling or edema to reduce is a key part of treating pressure hydrocephalus. And I have listed here the main things that they would try. One would be hyperbaric oxygen therapy, reducing the temperature of the body, adjusting the IV fluids so that the body kind of gets rid of some fluid, and they do that by adjusting the salinity of it. They give them a hypertonic saline solution. There are drugs such as mannitol that reduce the swelling. The ventriculostomy can be used not only as a means to test, but also as a means to drain fluid and reduce pressure. And then if it's really severe, if you work with really severe traumatically brain injured people, you will see this where they have removed a part of the cranium. They've taken a great big plate size off the side of the head and then covered it over with skin, and so that there's some place for the brain to go. And so it would, push out slightly, but it's better than the alternative. And then typically after that, they're over the acute phase of the illness, and it may be months, they will replace that skull, because obviously it's a dangerous situation to have a piece of the brain, a part of the brain that's not protected by a skull. All right. Now, if somebody has chronic pressure hydrocephalus, that means they have pressure hydrocephalus, And it's not going to go away with some of the treatments that we've listed up here, and they kind of get over it. They would do something called placement of a ventriculoperitoneal shunt. And that is a very small diameter tube that goes from a ventricle through the cranium, through the skull, under the skin, down the back of the neck, and into the peritoneal cavity, which is the body cavity. And this tube has a pressure valve in it, which opens up when the CSF pressure achieves a certain level, and then closes after it reduces the pressure a little bit. So it's constantly adjusting that pressure and draining off any excess fluid into the body cavity, where it's just simply absorbed. If you open up the body cavity, it's wet in there, and the composition of the fluid in the body cavity is essentially the same thing as cerebral spinal fluid. So it just reabsorbs it into the body in a very natural way. And then some people, after they have suffered brain injury from the hydrocephalus itself, require rehabilitation. Typically, if it were only the hydrocephalus, they would need cognitive rehab, maybe swallowing. It just depends how bad it is. Also, the brain injury that results in the edema and the hydrocephalus can itself be a source of of great functional deficits. So I'll invite questions certainly when we're in class about that. Also, I'm going to post a little lecture on the ventricular system and this production, flow, and uptake of cerebral spinal fluid, just as an option for you if you feel kind of shaky in that area and you want to know a little bit more about where the drains are and stuff like that. There's a lecture, but it's not actually really, I'm not going to test you on it. But it's really good stuff to know. Okay, now we're turning to intracranial neoplasms. Those are the tumors and the tumors and the cancers. And there are, this is a slide that shows the comparative frequencies of the different kinds of tumors that you might encounter, tumors or cancers. And if you have a patient who has a dysphagia or a dysarthria or an aphasia or a cognitive disorder as a result of one of these, obviously you want to know something about the normal course of events with, for example, a glioma. And for that, I would suggest using that book, Current Medical Diagnosis and Treatment, the latest one you have, and I know I mentioned it before. And you can look up glioma, for example, if you have a patient, and in just 3 or 4 pages, you see, what the presenting signs and symptoms can be, how it's diagnosed, and what the treatment options are, and the prognosis. Now, I wouldn't try to totally figure it out by myself and go without talking to anybody, but it allows you to have the opportunity to go ahead and do your evaluation and write up a evaluation report, which generally you don't go home and think about it, you write it up right then. And so you may not be able to talk to anybody about the patient's prognosis, and you don't want to have a wildly inappropriate prognostic statement when you can simply look it up and have an idea about the range of prognoses and the chances of recovery, et cetera, et cetera. So that's how I use that book when I encounter something like one of these as the etiology of one of my patients who has dysphagia or anything else that the SLB treats. This again is what's the diagnostic process. And here's a reference to the book I mentioned. And this is the latest one. It comes out every year, actually, and you don't have to get it every year, but it's a good idea to have one that's relatively recent or have access to it. And it does come, you can get it, by the way, downloaded onto your device. Obviously it starts with a history and physical. A CT scan or an MRI scan can identify most tumors and cancers. Sometimes they will do a biopsy where they can penetrate, actually without surgery per se, but penetrate through the skull with a needle and remove just a tiny bit of the tissue to see what exactly kind of tumor or cancer it is. and sometimes laboratory studies of the blood. So those are the main diagnostic tools that can lead to a diagnosis. Here are the categories of treatment for neoplasms: surgery, of course, radiation, chemotherapy, combinations of those. Sometimes, of course, people are left with neurologic deficits that require rehab. And if they have a reasonable prognosis of some significant period of survival, which many do, they can benefit from a rehab, just like a stroke patient may be able to benefit from rehab. Because in the case of a tumor, you can have obviously a localized signs and symptoms. You can have a hemiparesis or anything else that you know about. You can have an apraxia of speech, certainly can have a dysphagia. And the other thing that occurs in the signs and symptoms of a tumor would be not only the focal, what I'm going to call focal deficits, the ones that tell what part of the brain is involved, but also confusion can evolve, or worse, a reduction in consciousness. Why is that? The tumor is located in one area. Why would they have confusion, which is more of the non-localizing sign or symptom? Because the tumor can push the brain in all directions. It may be located in the left temporal lobe, but it's exerting its pressure in all directions. So you can have all parts of the brain being squeezed, basically, and that's where the confusion and ultimately loss of consciousness would come from. If you know the Rancho Cognitive Function Scale, you kind of know how the progression of cognitive deficits would go if somebody started with a small tumor that may have a localizing sign or symptom, and as it grows bigger and begins to affect cognition more, the individual is going to progress downward on that scale to eventually being unresponsive. Okay, now let's look at non-viral infections. These are infections of the brain. Infections of the brain that are just not viral in nature. They can be bacterial, and some of them can be fairly well successfully treated because non-viral infections we have more medical options for. Some of them can produce localizing symptoms and signs. For example, a brain abscess can produce signs like a stroke. Some of the more generalized bacterial meningitis is sort of like all over the meninges, and the same thing with encephalitis, can be all over. So it can produce cognitive changes from very mild to severe, and not necessarily focal. Now this is an odd category, this last one, infections by protozoa and worms. Why is it here? It doesn't seem like it has much to do with bacterial meningitis. The reason is it's an infection and it's not a virus. So that's why it ends up on this categorization. The diagnosis for non-viral infections of the brain are very similar to what you know already: history and physical, of course, CT and MRI scans, laboratory studies, usually of the cerebral spinal fluid. For example, if somebody has meningitis, it's going to show up, the organism that's causing it will show up in the cerebral spinal fluid. They're going to be treated pharmacologically, sometimes palliative measures. And I know I had palliative measures on the slide about the treatment of tumors and cancers, and I failed to mention it. Palliative measures are comfort measures. They're generally something you always want your patient to be comfortable, of course, but they're especially prominent in the treatment of hospice patients, patients who are dying, but the object of the palliative measures is to keep them comfortable. And then sometimes rehab. I had a patient who had herpes encephalitis, and it was very focal. He had a Broca's aphasia and a right hemiparesis, and he was in acute rehab, and he did rather well. He was severe, but he did rather well. And then, you know about herpes, it kind of comes and goes. He got better, and then he had a relapse and got much worse. So it was, but rehab can be appropriate, of course, after the disease, the causing disease has been treated and remedied, and then they're left with neurologic deficits, which can be rehabbed. Here are viral infections, and you recognize some of them. Here's the herpes. I think I miscategorized when I said herpes before, but here's herpes, polio, viral meningitis, viral encephalitis, rabies. AIDS. Those can be treated, some of them with some degree of success, but it's generally viral infections are not as treatable as non-viral infections. This looks very familiar. It's kind of the same lineup of tests and assessment procedures that result in a diagnosis, and then treatment, pharmacologic treatment, palliative measures, and rehab. So it is very similar. The actual medicines are different, but other than that, the approach is very similar. Okay, now we're going to turn to something which is going to be much more common for most of you if you work in healthcare, and that's transient ischemic attacks. I'm sure you've heard about TIAs. Sometimes they're called mini strokes, and in theory, they're not really a stroke, but they're kind of going in that direction. I want to start by defining this term ischemia. The name of this category is called transient ischemic attacks. What's ischemia? It is a local and temporary deficiency of blood supply due to obstruction of the circulation to that part. So basically, an artery gets at least partially blocked. Could be a very small one or it could be a big one, enough to produce a dysfunction of that area. Now, if the area that's being caused to be dysfunctional by this blood circulation problem is an area that expresses itself, now what do I mean by that? The motor strip. If you have ischemia in a motor strip, you're going to have a weakness of the part of the body that is controlled by that part of the motor strip. Let's say it's the face area on the right. You're going to have a left facial weakness of some sort that shows up. So that would be an example of a localizing deficit. Typically, if somebody has ischemia caused by the deprivation of blood supply in a particular artery to a quiet area of the brain, for example, let us say the prefrontal lobe, way out here in Brodmann's area 9, 10, and 11, they actually don't have any signs or symptoms at all, because that part of the brain, and it's a big area way out here, both sides seem to do the same thing. So if you have a area of ischemia or even a fully completed stroke from the same process, we'll get to that, it doesn't express itself with any signs or symptoms. That is, that somebody can have a big stroke in that area and never know they have it. How would they even discover they did have it? Usually that person has problems with blood circulation, and sooner or later they have a stroke that does lead to localizing signs and symptoms. They go to the ER, they do a CT scan, and they see not only this new stroke, wherever it is, but this old one that did not express itself with any signs or symptoms. So that's what I mean by saying the ischemia can be localizing, produce a localizing sign or a symptom or combination, or completely non-localizing and in fact asymptomatic. All right. Now, I skipped one, so we don't want to do that. Here. Now, you know what ischemia is. Now let's go back to the term transient ischemic attack and define it a little more precisely. It is an ischemic event, meaning some blood supply was deprived to a part, in which the clinical presentation, i.e. the signs and symptoms, last less than 24 hours. Let me give an example. Somebody develops a right hemiparesis. They go to the hospital, they do some tests, they figure out, well, he's either had a stroke or a TIA, and the next morning they wake up, they're completely fine. They are going to diagnose that as a TIA because the signs and symptoms went away within 24 hours. It is a warning sign of a CVA. They're going to try to diagnose and see what really happened. Even in a TIA, even though everything is fine 24 hours later, they want to diagnose it because, well, if they can treat the problem, they may prevent a TIA from coming again or causing a stroke, the same process, which we'll get into the details of what that process is, but they're trying to prevent a stroke and diagnosing it and taking the TIA as a warning sign. By the way, a lot of people who have TIAs, they never go to the hospital. They say, I'll wait around, see what happens. A few hours, they're okay, and they don't bother. And so those people are putting themselves at risk for a major stroke. There is another category of disease that I thought I should put on this slide. However, I never see it much. I mean, it's in the books, it's in the textbooks, but I never actually see it in patients' charts. It's the same thing I just described, only instead of 24 hours, the signs and symptoms go away someplace between 24 and 72. In other words, by 72 hours later, they're okay, but not by 24. And so they'll call it a RIND, reversible ischemic neurologic deficit. You know, these hours are very precise. 0 to 24, it's a TIA, 24 to 72, it's a RIND. In reality, it's not quite that black and white, and I don't think that signs and symptoms go away 100% so clearly that they even bother using this category. So if it's roughly around 24 hours, it's going to be diagnosed as a TIA. If it's significantly more than 24 hours for those signs and symptoms to go away, or maybe they never go away, that's going to be a CVA. All right, so hopefully that makes sense. And we're going to go on now to cerebral vascular accident. Or a stroke. See, it's more commonly called a stroke. And so let me get to the right slide here. It's a general term. A CVA is a general term most commonly applied to cerebral vascular conditions that result in either of two things. Either an ischemic lesion, which we sort of talked about, and we just talked about transient ischemic attacks in which the signs and symptoms go away in 24 hours, but that would be, if that actually leads to brain damage, that would be an ischemic lesion. On the other hand, if somebody actually has a breaking of a vessel that leaks blood into the surrounding tissue, that's a hemorrhagic lesion. So ischemia involves depriving an area of the brain of its blood supply. And the area does not necessarily die. If the deprivation goes on long enough, it does, and we'll talk about that. Versus a hemorrhagic lesion is a lesion in the brain caused not by deprivation of blood supply, but a breaking of a vessel and leaking of blood into the surrounding tissue. Both of them are strokes, and they're two different kinds. So we have two different kinds of strokes or CVAs, hemorrhagic CVAs and cerebral infarctions, which are called ischemic CVAs, because they're CVAs that involve deprivation of blood supply. Now, I'm going to jump ahead just to mention something about this ischemia. There are two ways that you can deprive of blood supply to a part of the brain. One is through a gradual disease process called atherothrombosis, which we're going to look at today as a part of this lecture. And the other as a part of a process usually caused by the heart forming a blood clot, which then travels up the arterial system someplace to the point where it can't get past because the arteries have gotten smaller, smaller, smaller as it goes further from the heart. And finally, it gets lodged, and then it deprives an area of blood supply there. So that's called an embolic CVA. And the one we're going to look at in detail is a thrombotic CVA, or atherothrombotic CVA, sometimes it's called. Either case, a embolic CVA or a thrombotic CVA involves ischemia as opposed to hemorrhage. So I'm going to go into that quite a bit more because I know that's maybe a little elusive at this point. Hemorrhagic CVA probably kind of makes some sense already. Let's look at hemorrhagic CVAs in a little bit of detail. They're basically classified by size. Small vessel hemorrhages, typically caused by hypertension and diabetes mellitus, both of which are very bad for your arterial vessel walls. And it starts with impregnation of small vessel walls with hyaline. And then it starts to add cholesterol to that. And so you get a breakdown and weakening of the vessel wall through this process of small vessel disease, and to the point where it hemorrhages. It'll actually, the vessel wall will weaken, start to balloon out a little bit under pressure, and then the little balloon, which is called an aneurysm, breaks, and there's your hemorrhage. they are small. These particular ones are class that we're talking about in this classification. They are by definition small, meaning 2 to 15 millimeters. That, you know, it's about like that, or smaller. And they are intracerebral, meaning they're within the brain tissue, not out on the surface of the brain. They may also be the cause of something called a lacunar infarct. Now, these, again, I'm talking about small vessels that get weakened walls through the formation of these weakened areas and a little aneurysm, and it breaks, and then it leaks blood into an area, a very small area, and that area then breaks down. It's not going to survive that process, and you'll get then a little bubble, very small, 2 to 15 millimeters, of fluid-filled space that shows up on a CT scan as a light area, and they'll call it a lacunar infarct. And the lacunar means like a little bubble. An infarct, you already know about an infarct. It's an area of brain injury caused by ischemia. Yet, I'm not describing an ischemic process here. I'm describing a hemorrhagic process. So by the time you get to a CT scan that shows a lacunar infarct, it could have been caused by a little tiny hemorrhage, described here, or it could have been caused by a little tiny infarct where the vessel was blocked and deprived the small area of blood, and then the tissue breaks down and there's your lacunar infarct. So I put quotation marks around it because the word infarct suggests that the process is an ischemic process, but it could be a hemorrhagic process, which is why I'm putting it here. And actually looking at that lacunar or lacunar infarct is not going to tell how it got there. It's all it says, it's small, very small area of brain injury caused by some problem with a very small cerebral blood vessel, whether it be a hemorrhage or an infarct. An intracerebral hemorrhage is this similar process, but just big. It's large. It happens with larger blood vessels, and it can be massive. It can make a great big collection of blood deep in the brain and can be fatal. So that would be called an intracerebral, for inside the cerebrum. Okay, now I skipped a slide, so let's come back to it. Subarachnoid hemorrhage. A subarachnoid hemorrhage is a hemorrhage that leaks into the subarachnoid space. Intracerebral is within the brain tissue of the cerebrum. Subarachnoid is within the cerebral spinal fluid that surrounds the brain in the subarachnoid space. And that is caused by some problem with one of the vessels on the surface of the brain. You know, when you look at the pictures of the surface of the brain and you see the middle cerebral artery and the anterior, it's those vessels that run on the outside of the brain. And they can have various kinds of aneurysms that typically were congenital. That person was born with them, but it was not a known problem because it just is it's a small little thing that usually, if it's going to break and hemorrhage, doesn't do it until they're in their 30s or 40s. And then they get a stroke, a hemorrhagic stroke involving a saccular aneurysm. It's a little bubble that looks kind of like a sac, a berry aneurysm, a little aneurysm that looks like a berry, raspberry or something like that, or an arteriovenous malformation, which is just a kind of a mishmash. I should show you a picture, but just an intermixing of vessels that are very abnormal. And they'll tend to occur where there's bifurcations and then there's just a big mess of vessels that has a strong tendency to hemorrhage in that period of your life. All of them can be treated, potentially be treated surgically or with radiotherapy, where they're shrunk down. Sometimes they're shrunk down with radiotherapy first and then removed. Sometimes because of accessibility issues, they cannot be treated successfully, but oftentimes they can. And the ideal kind of situation is where somebody develops headaches. They go to get it diagnosed and they find that they have one of these things, and they do surgery to clip it out of there and repair it before it ever hemorrhages. So that does happen. Obviously, there'd have to be some sign or symptom in order for the diagnostics to take place that would diagnose that. And then the last category are the subdural and the epidural hemorrhages. And I put it in here because we're talking about hemorrhages, but they're not actually strokes. Subdural and epidural hemorrhages are hemorrhages in some place in the cranium, and this tells where, just beneath the dura, or just superficial to the dura, between the dura mater and the bone itself of the cranium. And they are always caused by trauma, a trauma that involves it could be a very slight fracture of the skull, that where the fracture crosses one of the subdural arteries, and it starts to leak. And it's leaking inside the skull, between the skull and the brain, and collecting a pool of blood, which is called a hematoma, and putting pressure on the brain. So I forgot the name of the comedian, but he died last month. You guys probably heard about it on the news. It was a big story. He was found in his hotel room after a performance, dead. And they didn't know why. They thought there was no foul play, but it turns out that they did find a small injury to the back of his head, and they think he had fallen. He'd fallen or hit his head on the head of the bed, or something had happened, and he just went to bed. He wasn't on the floor, so he went to bed, went to sleep, and then while he's sleeping, the hematoma develops bigger, 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 bigger as it's collecting his blood, until the point that the brain had so much pressure on it that he died. So this is not a stroke again. These subdurals and epidurals are the results of trauma. Okay, now let us get to cerebral infarction. And we're going to define it first. It's the formation of an infarct, which is an area of tissue necrosis caused by ischemia, not caused by hemorrhage, caused by ischemia. So in order to be called an infarct, the tissue has to die. Keep in mind now, sometimes areas of the brain get deprived of blood supply just enough to cause dysfunction, but then the blood supply kind of restores itself, and there's no actual necrosis. That could happen in a TIA. And we'll look at that particular little detail in a moment, a little bit more. And there are two types of ischemic infarcts. I made reference to this earlier. One is an atherothrombotic infarct, and it's also called a thrombotic infarct. It's a little easier to say, so I think I'll choose that one to say from now on mostly. And then an embolic infarct. And in an atherothrombotic infarct, there's a disease process that goes on usually for years, that gradually makes an artery get more and more and more narrow until it just can't quite pass enough blood to maintain the vitality of a certain part of the brain, and you get a stroke. In an embolic infarct, typically a clot forms in a heart that is not beating properly. And we're not going to look at that one in this particular lecture. That's going to be the start of the next lecture. So we're just going to deal with thrombotic infarcts today. But both of them involve ischemia and ultimately tissue death because of the ischemia. Okay, now let's look at the process leading to an atherothrombotic infarct. There is a gradual stenosis, and that means narrowing of the lumen of an artery to the point where the occlusion or blockage is large enough. Doesn't have to be 100%. It just has to be large enough, whatever that might be, and long enough, of sufficient duration to actually result in tissue death or an infarct. The actual degree of occlusion is variable and dynamic, as I'm going to explain in a few moments, but let me kind of jump ahead so I can give it to you twice. Your major arteries have smooth muscles encircling them. They're actually in the walls, and they are capable of contracting and thereby reducing the diameter of the vessel or the lumen of the vessel so that less blood can flow through it at that moment. Now, it's normal to have those smooth muscles in there. And you don't have them in the little tiny vessels, but you have in the major vessels, certainly like in the common carotid, is relevant to us as SLPs in the common carotid and the internal carotid, that they are there. And they're constantly contracting a little or relaxing a little, depending upon what you have to do at that moment in time. For example, after a big meal, you need to get more blood to the digestive organs. And so the major arteries going to the digestive tract open up a little bit. The smooth muscles that I'm describing relax, letting more blood go there. And actually, you'll tend to get a little groggy after a big meal because the vessels going up to the neck in kind of an exchange system have closed down a little bit. So you're getting more blood down here to the digestive area, less blood to the brain because you don't need the brain to digest. So for the different needs of the moment, the body is capable and does adjust blood flow to different parts up a little bit or down a little. So that's the purpose of the smooth muscles. Now, what happens in the thrombotic disease process is that those smooth muscles begin to multiply themselves. You actually get more. And that's what I mean by proliferation of smooth muscles within the walls of major arteries. And here I give that purpose again. Smooth muscles are normal and serve to regulate the flow of blood to different parts of the body, depending on what is needed in the moment. The abnormal proliferation of those smooth muscles tends to occur at certain locations in the arterial system. And those locations are where there are bifurcations or curves. The reason for that is because at those locations, you have greater hydraulic forces. Let me jump ahead to say that if you have high blood pressure, this process that I'm describing would tend to advance faster. Why? Because the hydraulic forces of the higher blood pressure put those parts of the vessels at greater stress. Literally from just like what would happen in a river. If you look at a flooded river, wherever there's a curve or a bifurcation, there's going to tend to be more erosion. So the same basic process is occurring here. They're highly prone to occur in some people at the bifurcation of the common carotid. So that's where we get into strokes that are relevant to us. And so that's the first step. That step actually, we know from research, from autopsies from wartime, starts in some people in the 20s. Not everybody, but some people get that proliferation of the smooth muscle starting that long before they would ever have a stroke, which would be more likely to be in their 70s or something along that line. So there could be a 50-year process easily. Second step is a depositing of cholesterol crystals among those proliferating smooth muscles. So you know about the relationship of cholesterol to this process, I think. And this two-part advancing of the disease, proliferation of smooth muscles and laying down of crystals, cholesterol crystals among them, results in a thickening of the arterial wall. And that area of thickening is called an atheromatous plaque or patch. Okay, here we go. Now, third step is a breakdown of the arterial endothelium. Now, the endothelium is the inner lining of the artery. And this is the step that probably doesn't occur until pretty close to when the person actually has a stroke. So they may be accumulating smooth muscles, proliferating their smooth muscles in these certain regions of the artery and getting cholesterol among them. But they don't get this step until much later. And eventually what happens is that the degree of thickening of the wall is such that it puts the endothelium under stress and it just breaks basically. And that results in a wound. Your blood reacts to wounds by clotting so that the blood flow stops. So if you cut yourself, you're going to get a scab, but before it's a scab, it's a blood clot and the blood stops flowing, hopefully. Why did it clot like that? Because blood has material in it. Basically, where is it? Oh, here it is, right here. Platelets and fibrin that results in coagulation. So they encounter a wound, they start to coagulate. So that occurs after the endothelium breaks down, and it's at that point that a stroke could occur. And if the blockage is such, the clot is big enough and the thickening is big enough to reduce the blood supply enough, You're going to get ischemia, first of all. And if that ischemia is long enough, and how long is long enough? I'm going to say roughly 7 minutes. If it's long enough, it will cause an infarct. In other words, the tissue that is receiving its blood will become necrotic. It will die and won't be functional any longer. So that would be the completed stroke of a thrombotic type. Why do I say 7 minutes? I'm taking that actually from the drowning. Typically, if somebody's underwater a minute or two and their breathing and heartbeat are restored right away, they won't suffer significant brain injury. But if they're underwater for 7 minutes or more, probably not going to survive it. So what's that tell us? Your brain tissue can't go without oxygen for more than just a few minutes. There are a lot of variables in there, but that's basically that's it. Now, this is the process. If the clinical presentation subsides within 24 hours, it will get diagnosed as a TIA. If it's longer, it will be diagnosed as a thrombotic CVA. Now, I want to go through, we're almost there, the factors that determine the moment of the stroke. Because we've got like a 50-year process here, the thrombotic disease process. Why do you have a stroke on Tuesday at 10 a.m. and not 2 days before or 1 day after? Well, the main variable operating is the atherothrombotic disease process. That's the main thing. If you didn't have it, you're not going to have an atherothrombotic stroke or a thrombotic stroke, and not everybody has it. You can be 90 years old and not have it at all. But of course, a lot of people do. But that's the main variable that's operating. It's progressing over years, making that lumen more and more and more narrow. The speed of the progression of that process is determined largely by genetics. Some people are genetically prone. Lifestyle factors, including smoking, is a big one. And health factors, including diabetes and hypertension. Something in smoke and the imbalances that are present in diabetes and the pressure that's present in hypertension subject the vessel walls to some form of trauma that results in them thickening up. Again, at certain points, bifurcations and curves. All right, in addition to that, so we have the 50-year process of atherothrombosis advancing. We have the things that affect it. Now, in addition to that, overlaid on it, we have the moment-to-moment variability in the diameter of the artery's lumen. Now, where's that coming from? I described it earlier. It's coming from the smooth muscles inside that are constantly contracting a little bit or relaxing a little bit to regulate the flow of the blood to different areas. So you might guess that you might be more prone to have a thrombotic CVA immediately after a big meal, and that in fact is the case. The other factor that is going to affect the moment of the infarction would be the availability of a collateral blood supply via the circle of Willis. Some people can have a huge blockage, but they get blood from the circle of Willis to compensate for it, and they don't have a stroke, or at least not yet. Other people don't have a circle of Willis that really works that well, and they'll have a stroke. So that's a factor operating. Other factors that are operating and varying all the time would be blood pressure. Blood pressure is a problem and it causes or exacerbates atherothrombotic when it's chronically high. On the other hand, somebody whose blood pressure drops significantly and who has atherothrombosis may be more prone then to have their stroke at that moment of hypotension, low blood pressure, because the blood pressure is not quite enough to push the blood through that narrowed area. Another factor would be, so obviously the goal is to keep the blood pressure in an acceptable range, not too high to make the thrombotic disease process advance, and not too low so that the blood can't get through the diseased vessel in a narrow range, in other words. Blood viscosity, which is the just plain thickness of the blood, and that varies all the time depending upon how hydrated you are. If somebody's more likely to have a thrombotic CVA if they are dehydrated, because literally their blood is thicker and doesn't go through the vessel as well. And then clotting time. Now that's not the same as thickness. It is a factor in the blood that determines how fast a clot will form. And you've heard of some of these drugs, or maybe all of them, that will tend to increase the clotting time. In other words, make it go slower. Make it go slower. And they're drugs like heparin, warfarin, which is also called Coumadin, Eliquis, and Xarelto. You hear those latter two advertised on TV a lot for older people who have atrial fibrillation, and their heart, as we'll see in the next section, tends to form clots. But even people who don't have atrial fibrillation sometimes take a drug thinner, a blood thinner, so that their diseased vessel doesn't tend to form a clot as much. And these are risk factors for atheromatous disease: smoking, hypertension, diabetes, obesity, heavy alcohol consumption, and exercise or lack of it. There's a lot of research on each one of these. The most clear one is smoking, hypertension, and diabetes. Those are huge risk factors. Obesity, well, it's considered to be a risk factor, but there are many people who are obese and don't have a sign of atherothrombotic disease. There's a lot of mixed research on alcohol consumption. Most of it seems to suggest that moderate alcohol consumption actually results in a reduced risk of atherothrombotic disease, better than no alcohol at all. But it's all over the place, so it's mixed, and it's all descriptive research. We don't have such thing as a controlled study on a question like that. Same thing for exercise, and under et cetera, things like stress, and there's a whole bunch of stuff that you can look at. All right, that is the end of the slides, and we will pick up then next time and go through embolic strokes, the ones that usually start with a heart problem, and then the rest of the etiologies, including the big one, traumatic brain injury. And I will see you later.